In the last video, we discussed the purpose of risk assessment and the types of risk factors being considered. We're now going to focus on how risk assessment and management are conducted, what tools are used, how decisions are made, and how we can understand the effectiveness of both. In practice, risk assessments are typically only conducted once per sentence for the average offender. Offenders may be reassessed if there are changes to the offender's circumstances, such as developing a mental illness or sudden increases in aggressive behaviour. An offender's risk will also be frequently re-evaluated if they are under what's known in Queensland as a forensic order or a treatment support order. Courts will issue these orders if the offender is found to have a severe cognitive or intellectual disability. These offenders typically require more intensive intervention efforts than most other offenders, so regular reassessment is crucial in these cases. Now, when it comes to actually managing risk, the current gold standard approach for risk assessment and management is the Risk Needs Responsivity Model, or RNR model. This model was proposed by Andrews, Bonter, and Hoge in 1990. This model outlines three core principles for effective offender classification and rehabilitation. The risk principle emphasizes that the intensity of a risk management plan should be proportional to the offender's level of risk. Essentially, this means that individuals who are at a higher risk of recidivism or violent behavior during their sentence require more intensive management. However, low-risk individuals should receive less intensive management, as over-intervening can actually increase risk. We can see an example of this in a study by Bonter and colleagues. They compared two groups of 120 inmates with both high and low risk levels. One group received a high-intensity treatment, and the other group received standard treatment. When they compared the rates of recidivism between the two groups, they found that 31.6% of high-risk offenders who received high-intensity treatment re-offended, compared to 51.1% of high-risk offenders who received standard treatment. However, 32.3% low-risk individuals who received treatment would go on to re-offend, making them slightly more likely to re-offend than their high-risk counterparts. Not only that, they were much more likely to re-offend than low-risk offenders who didn't receive treatment, of which only 14.5% went on to re-offend. In practice, this finding makes sense. Intensive programs can expose low-risk offenders to antisocial peers who reinforce or encourage criminal behavior. Alternatively, high-intensity intervention can also target problems that low-risk offenders don't or aren't likely to have. And this brings us to the second principle of the RNR model. The need principle refers to the offender's criminogenic needs. Criminogenic needs are dynamic risk factors that have been directly linked to criminal behavior. These essentially represent the reasons why a person might engage in criminal or antisocial behavior. As such, interventions should ideally target an offender's criminogenic needs in order to reduce their level of risk. Because criminogenic needs vary between individuals, it is essential to identify those that are specific to the individual. Addressing issues that do not contribute to an offender's overall risk offers little benefit and may even reduce engagement with the intervention. This highlights the importance of the third principle, responsivity. The responsivity principle advocates for rehabilitation efforts to be structured in a way that maximizes an offender's engagement with the intervention and retention of its content. This involves tailoring the delivery of the program to the individual's cognitive abilities, motivation, and cultural background. Interventions may also be more effective when they acknowledge and build on existing protective factors, such as strong family support, pro-social goals, or a personal commitment to change. Now, how do we actually collect all of this information? Well, there are three different types of risk assessment that fall under two broad categories: structured and unstructured. Structured risk assessments consist of a standardized and fixed set of tools or questions that take an evidence-based approach to estimating risk. Unstructured risk assessment, on the other hand, may or may not contain empirically validated tools or questions and have no predefined criteria for what should be included. The earliest approach to risk assessment was unstructured and is referred to as clinical judgment. In this approach, the clinician selects which risk factors to consider based on their experience and intuition without using standardized tools or scoring systems. The goal is often to construct a narrative that explains the offender's past behavior and anticipates future risk. While this approach allows for a personalized and holistic view, its accuracy depends heavily on the clinician's prior experience, which can often be biased and unreliable. For example, research has shown that clinicians using unstructured clinical judgment may apply the same risk factors to both violent and sexual recidivism, despite these behaviors having distinct causes. This reflects a broader issue. Like all decision makers, clinicians are prone to cognitive biases. such as overgeneralizing from past cases or relying on particularly memorable examples, which can lead to inconsistent and inaccurate assessments. Structured risk assessments, on the other hand, provide clinicians with a list of risk factors that have been observed to collectively contribute to a person's risk of recidivism. These tools are designed to increase consistency, transparency, and reliability in the assessment process over unstructured approaches. The first type of structured risk assessment is called actuarial risk assessment. These tools use statistical models derived from large data sets to estimate a person's risk. An assessor will score the presence or absence of a fixed set of risk factors. These are then added together to obtain either a percentage or categorical estimate of the likelihood of recidivism. Some of these risk factors also may be weighted more heavily than others, as some factors are associated with a stronger likelihood of recidivism compared to others. Importantly, actuarial tools primarily assess static risk factors. While some can identify dynamic risk factors, they generally offer an estimate of an individual's long-term risk at a single point in time. This makes them less useful for monitoring changes in risk and therefore have limited value for informing risk management plans. Structured risk assessment tools are usually constructed to be administered in certain populations. For example, the Violence Risk Appraisal Guide Revised is a commonly used actuarial tool used to assess the risk of physical violence in adult male offenders. Administering this to a population of adult non-offenders or even juvenile male offenders will return an inaccurate estimate because it assumes a baseline of prior criminal history. Additionally, the Violence Risk Appraisal Guide cannot be used to provide an estimate of general recidivism or recidivism for another type of offence, such as sexual offences. For anything other than assessing the risk of violent recidivism, other actuarial risk assessment tools should be used. The second type of structured risk assessment is called structured professional judgment, which is a hybrid of clinical and actuarial risk assessment. An example of a commonly used structured professional judgment tool is the Historical Clinical Risk Management Scale, version 3. As you can see, like actuarial risk assessments, structured professional judgment tools provide assessors with a checklist of predetermined risk factors based on statistical models. However, this approach allows clinicians to have flexibility in determining the relevance or impact of risk factors. While the final output of actuarial tools is based on the additive score of observed risk factors according to a formula, structured professional judgment requires the clinician to estimate the overall risk level. For example, let's say an offender presents with a diagnosis of schizophrenia. Under the HCR20, a diagnosis of a major mental disorder is considered a relevant risk factor and therefore marked as being present. However, if their disorder is well managed and unrelated to their past violence, the clinician may judge it to have low relevance to offenders' risk of violence. Now let's say this hypothetical offender also presents with other risk factors, including difficulties with substance misuse and irritability. Despite this offender having multiple risk factors, given the low relevance of their disorder and depending on the impact of the other risk factors, the clinician may judge their overall risk to be moderate instead of high. Structured professional judgment tools also differ from actuarial tools by including a combination of static and dynamic risk factors. This means they can be used not only to estimate risk, but also to monitor changes over time and inform ongoing management and intervention strategies. The aim of this approach is to incorporate the flexibility of unstructured clinical judgments to create a more holistic and individualized representation of the individual, while retaining the empirical validity of actuarial risk assessment. So which approach to risk assessment is better, structured or unstructured? When we evaluate the effectiveness of risk assessment, it's important to make sure it both correctly identifies who will go on to reoffend, but also correctly identifies who will not go on to reoffend. This brings us to two important concepts in the field of psychometrics: sensitivity and specificity. Let's say we're trying to determine whether someone is likely to reoffend. We have two possible decisions. 1. They are likely to reoffend. 2. They are likely to not reoffend. However, you can see in this table that there are 4 possible outcomes, these being true positives, false negatives, and true negatives. We want to make sure that we're maximizing the potential for true positives and negatives while minimizing the potential for false positives and negatives. This is where sensitivity and specificity come in. Sensitivity refers to how likely a tool is to pick up on risk factors and correctly identify someone who will reoffend. We can calculate the sensitivity of a diagnostic tool or risk assessment by dividing the number of true positives by the number of true positives and false negatives. Specificity, on the other hand, is how likely a tool is to identify someone who is likely to not reoffend. This is calculated by dividing the number of true negatives by the number of true negatives and false positives. Essentially, sensitivity is about capturing true risk, while specificity is about avoiding false alarms. A meta-analysis by Villon and colleagues published in 2025 compared the predictive accuracy of structured and unstructured risk assessments. When they accounted for the sensitivity and specificity of both these approaches, unstructured risk assessment performed quite poorly. They had an average likelihood of between 61 and 62% for correctly predicting recidivism. Comparatively, structured risk assessment was on average between 68% and 72% likely to correctly predict recidivism. While the difference between these two results might not seem that great, considering that 50% is essentially a coin flip and the variability in human behavior, structured risk assessment performs adequately. Between actuarial risk assessment and structured professional judgment? Well, variances in the statistical reliability and validity of individual tools exist. However, both approaches to risk assessment are equally valid. Ultimately, it depends on the purpose of the assessment and the context in which it's being used. Actuarial tools are faster, easier to administer, and provide consistent and usually more specific estimates of recidivism. However, they offer little information about an offender's criminogenic needs or protective factors, which can guide intervention and rehabilitation. Structured professional judgment tools, while more time-intensive, provide richer information about an offender's criminogenic needs and responsivity, making them more useful for developing risk management plans. Regardless of the method, the ultimate aim of risk assessments are the same: to make informed, ethical, and evidence-based decisions that protect the public and support successful rehabilitation.